Yeah. Hi, everybody that is on the call. My name is Sharon Gardner. That's okay. Thanks for the message, Michelle. I'm Sharon Gardner from H&I Healthcare. I am the Clinical Services Manager, and I've got Linsey Peters on the call with me. I'll let her introduce herself.
Hi, I'm Linsey. Thank you for joining. I'm working with El Messi-Tran in the Netherlands, and I'm working there as a research associate. So we provide all the scientific input behind the product.
So hopefully you are on the correct webinar. Today's webinar is looking at non-healing wounds. So we'll go through some of the basics, the etiology, the factors as to why we have obviously lots of non-healing wounds. Please keep your mics and your cameras turned off. I know Ellie's just popped a comment in the chat box. It just helps with bandwidth, and then obviously you being able to hear us. The webinar is being recorded. It's just so that we can use it again if anybody wanted to access it that couldn't today. I'll be presenting part of the presentation and Linsey will be doing part as well. There is the Q&A tab, which you should all be able to see at the top of your Teams if you wanted to ask a specific question, but we're all used to using the chat box as well. So if you had a comment or question, please do use the chat box as we go along. There are other members of staff from H&I Healthcare in the call, so they can pick things up as we go along, or we can certainly have some questions and answers at the end. So I'm going to make a start. I do have to apologise. I have got 2 dogs who bark if the doorbell goes, and I am waiting for a parcel to be collected for work. So I'm praying that DPD gods are on my side today. So if I do mute my microphone for a little second, it's only to give you all your ears a piece. So do you want to share your screen, Linsey, and then we can make a start?
Yes.
We're doing it a new way through Teams, so we've had some technical challenges this morning. Otherwise, we'd have got you all admitted to it a whole lot earlier. So just bear with us. We're hoping this is all going to go as smooth as butter.
Yeah, I'm sharing. I just cannot seem to give you the control. So
that's fine. We'll just have to do next slide like we did through COVID.
Yeah.
So obviously I've already introduced ourselves. You know now that you've got myself and Linsey on the call. Yeah. So just a quick definition really about non-healing wounds, and you'll probably hear these referred to in different terminology. So it may well be that they are referred to as a chronic wound, or there are other terminology that's used around non-healing wounds. There was a best practice statement done quite recently around non-healing wounds, and it's felt that actually non-healing wound has more of a positive impact on patients and us as clinicians rather than chronic wounds. So what is a non-healing wound? Well, it's a wound that develops due to a reason, so an interruption in the body's natural healing process. We all know, don't we, what the normal stages of wound healing are. We all know that our wounds have to go through those normal stages, and actually, our body needs to be in an optimum state, doesn't it, to ensure that it's able to heal our wounds. We help this process, don't we, as clinicians? We use lots of different products, lots of different things to help our patients' wounds heal through the normal process, because we know that most of our patients have got something that's going to sort of put a halt in that process. So what do we actually mean by non-healing? Well, we would expect, wouldn't we, that within the normal parameter of that wound healing process, that you would get some form of healing, granulation, reepithelialization within 4 weeks of optimal therapy. And we'll talk a little bit further on what we mean by optimal therapy. We would also expect that if it's a rather large wound and we know that it's going to take longer than 4 weeks to heal, that we would see a reduction in the size of that wound by at least 40%. So that's what we classify as a non-healing wound. It's also really important to mention that obviously we have lots of other wounds, don't we, that aren't going to heal through the normal healing process. So our atypical wounds, our malignancies, our autoimmune related skin conditions. So it's always worth ensuring that when you are assessing a wound that is not healing, that you have that atypical wound consideration in the back of your mind as a diagnosis. Next slide, please, Linsey. So what is actually going on? What is going on in our bodies or our patients' bodies when these wounds aren't healing? So we already know that non-healing wounds are those ones that haven't done what we expect them to do. And quite often they stall, unfortunately, in the inflammatory stage. So they've gone through that very early hemostatic stage. You know, the body, providing it had enough clotting factors, fibrin, you know, the body's able to clot that off, and then it moves it very quickly, doesn't it, until the inflammatory stage. And unfortunately, this is where wounds tend to stall. Despite differences in etiology of wounds at molecular level, this is where these wounds all share some common features. So what we see excessive levels of pro-inflammatory cytokines. We see excessive levels of proteases and reactive oxygen species. We see cells that are degrading with age and can't replicate. You know, we all know that aging is a blessing. It absolutely is a blessing to all of us to get older. But as we get older, things change, don't we? So we see that dysfunction and that deficiency of those really, really important stem cells. And we know, don't we, in this non-healing wound biology, they are often infected at some level, you know, chronically infected, systemically infected. So we do know that because our skin is our bubble wrap, it's our barrier, isn't it? It protects us from outside contaminants, bugs, viruses. As soon as we've got a break in that barrier, we know that we then have this opportunity for anything to get through. So we know that we do see that these wounds are in this persistent barren inflammatory profile, this persistent inflammatory stage. So we know that, you know, due to repeated tissue injury, microorganism invasion, lots of changes with platelet derived factors, you know, looking at our growth factors, our extracellular matrix, you know, they all become damaged, don't they, by everything else. We've got this toxic wound environment, if you like. Toxic's probably a little bit of a harsh word, but we've got this environment where we've got too many of the things, the MMPs, too many of the deficient cells that aren't able to replicate and build this really healthy, granulated wound environment. And all the time, our body's trying to put in the right things. So put in the fibroblasts, the extracellular matrix to really, really encourage this really, really healthy wound healing. But unfortunately, because there's too many of the baddies in there, your goodies can't quite overcome it, and you're stuck in this cycle of this inflammatory non-healing stage. So next factor. So what types of wounds do we see? And this is obviously not an exhaustive list. You know, you're probably sat there now thinking about patients that you've got in your clinical environments, in your wards, that have got wounds that just aren't healing. But commonly we see the most common non-healing wounds are our ulcers, so our leg ulcers, you know, vascular etiology, mixed etiology, arterial etiology. And we know, don't we? We know the reasons why they don't heal or why they struggle to heal. We know that because our leg ulcers, because our diabetic foot ulcers, because our pressure ulcers are all there because there's a problem, isn't there? There's a problem in the body. Your patient's got diabetes. Your patient's got poor vascular supply to the lower limbs. Your patient's immobile and actually can only sit in one position. So we know already we've got a problem there that sometimes may well be out of our control. But can we say that we've done that thorough holistic assessment to be able to provide the optimal care? So going back to that definition at the beginning, what's the optimal care? Obviously, we know that infection impedes wound healing. Ischemic wounds, so going back to our leg ulcers, our pressure ulcers, has our blood flow been compromised for some reason? It's not able to get that lovely oxygen-enriched blood down to the wound to help all this activity, to help those wounds move through those stages of wound healing. Surgical wounds, you know, they're closed with primary intention. They are really clean wounds, aren't they? But actually, what happens afterwards? And then obviously I mentioned at the beginning about our umbrella term of atypical wounds, our oncology wounds, trauma wounds, injury, any other wounds. So any wound that's occurring on our patient's body, on the skin, that is for whatever reason not healing. So it's all of them, isn't it? All of our wounds have the potential to not heal. Next slide, please, Linsey. So why? What makes this happen? Well, we know, don't we? We know there is multitude of factors. It's no surprise, is it, that these wounds become non-healing? You know, we know the data from all the data that Julian Guest and authors collected over the years, looking at actually how many wounds are there, we know that there are so many wounds out there that are just not healing. So, you think about your patients. How many of my patients have got diabetes? How many of my patients have got other comorbidities? And we know that obviously diabetes gives an increased risk of major complications in wounds, which include infection, include limb amputation, vascular changes, neuropathic changes, immune function, and all other biochemical abnormalities all contribute to this delayed wound healing in patients with diabetes. And even careful wound care in a patient with a really excellent glucose control may fail because there are other things going on. And we know, when our patients have chronically infected wounds, that in itself gives rise to increased blood glucose levels. Obviously, high cholesterol, severe injury. Was the wound a really, really significant wound in the beginning? Has your patient had cancer? Have they got cancer? Have they got a depressed immune system? We've already touched on vascular disease, heart disease, hypertension. Elderly, as I've said, our skin is not able to replicate our skin and all the underlying cells and structures. As we get older, the functionality just decreases. But we also know, don't we, if we're lucky enough to get a bit of sun, depending on where you are in the world, the sun induces changes in the structure and function of the skin, resulting in thinner skin, less elastic, less really, really enriched collagen that we need to build that healthy wound healing. And we know that non-healing wounds are prevalent in the elderly. We know because of that link to comorbidities. Immobility, obesity, or poor nutrition. We know about, if you're having a balanced diet, if you've got to have some surgery, have your balanced diet, get your protein, get your carbohydrates, because that's what's going to encourage and promote that healthy wound healing. Smoking's a really interesting one. We know how many nasties are in cigarettes, don't we? We know. We don't probably fully understand what's going on with vapes at the moment, but we know smoking. And actually, when you look at the data, certainly in the burden of wounds data, smoking was actually the one commonality that appeared in all these patients. They're looking at this random selection of patients. Smoking was the one commonality. Anemia, linking in with vascular issues, multiple surgeries. And then you've got all your other stuff. So you've got your wound-related problems. What's going on in the wound? Is it because of all these other things? And then us. What's going on in your organisation? Are you busy? Are you knackered? Are you short-staffed? Are you being expected to see significantly more patients than actually what you should be doing? So there's a whole host of factors, isn't there, that contributes to a non-healing wound. And actually, if we can have some impact on some of these factors, we're going to reduce the number of non-healing wounds that we're going to see, which in turn is going to improve our organisation-related problems. Next slide, please, Linsey. So the money, let's talk money. We all like to get chatting about money, don't we? The cost of living, everything's on the increase. Petrol and diesel in the UK is going ridiculous again for some unknown reason. But money, not only is this an impactful problem for all your patients, the risks that it carries to your patients, an impactful problem for you, for your teams, for your clinicians, when you're juggling so many different plates and you don't want to let one of them drop. But actually, non-healing wounds is a global problem. It's estimated that globally that there is about 2.2 per 100 population of patients with non-healing wounds. And obviously, the number of individuals developing non-healing wounds is increasing day on day, isn't it? Changing lifestyles. I had a conversation with someone just before I came on the call about mobile phones and research around the impact of mobile phones. So we live in a world that's very fast-paced and changing our lifestyles. But equally, medical science is amazing. We're keeping people alive longer. We are able to treat more people, and that all has a massive impact on what it costs. I've talked about Guest. He noted that there was a 71% increase in the annual prevalence of wounds between 2012 2013 and when they recollected the data, which was 17-18. And that's a massive amount of expenditure, isn't it? But how much are we paying? How much does that actually mean? So of all those wounds, that 71 increase in the non-healing wound amount, it's disproportionate in when you look at total wound expenditure. 67% of total wound expenditure goes to these non-healing wounds, and that's a massive, massive burden that's obviously going to continue. Generally common in community settings. I was a DN, I've come from community background, but generally it's more of a problem because you have a higher incidence of patients on your books with wounds. Next slide. So what impact does this have? You know, we've already talked about the impact of the NHS financially. We all know that the NHS is massively struggling from a financial point of view. I heard some statistics the other day of how many vacancies there are, nursing vacancies across the UK, and it's absolutely staggering the amount of nurses that have left, leaving. I saw one person randomly on a Facebook post she'd commented in on TUI, so off on your holiday. She's just finishing a nursing degree and she's applying to be cabin crew. You know, it's having a massive impact on the NHS. We know about staffing crisis. We know about the challenges you're facing, but actually, what about our patients? So what about lovely Stan there in his flat cap? You know, patients now are more aware, aren't they? We have expert patients. Most people have some form of electronic device that they can read up. They can do their research. They can go on Google themselves and find out lots of information. So, you know, they are very challenging. They are suffering. They are struggling. But equally, you know, they know what they want. You know, I work as a nurse in a walk-in centre. I see and treat and prescribe, and the amount of patients that come in and say, oh, I just need some antibiotics, and they don't. You know, we know about antimicrobial resistance, so we are having the challenges of managing patients who, quite frankly, are fed up, they're distressed. It's having an impact on their life. So what do we need to do? Well, you know, successful outcomes for our patients rely on us as clinicians doing a really good, accurate holistic assessment. So doing that holistic assessment in the beginning to be able to provide that optimal care. So we're doing that from day one. We're pre-planning. We don't want this wound to become a non-healing wound because we know that our lovely Mr. Flatcap here is diabetic. He's a smoker, but he's trying to give up. He doesn't eat well because he's on his own. So we're already thinking, right, okay, my lovely patient has got these factors. I'm going to try and improve some of them, and I'm going to plan. And what I'm going to do is I'm going to follow up that plan. So if I think I've provided the best wound care for my lovely little man, I'm going to look at that again in 2 weeks. I am going to go back. I'm going to be the one that goes back because I saw him first. So I'm going to make sure that I am really, really reviewing and assessing that. Next slide, please, Linsey. So obviously I've talked about non-healing wounds, haven't I? And we know that non-healing wounds, like I've already said, usually have a problem with wound infection. And I think it's really important here that I mention these two documents, and I'm happy to send the links in the chat in a minute so that you can access these documents. So the green one is the Wound Infection in Clinical Practice, which was the updated best practice document, which was launched last year, and it's an absolutely brilliant document. It talks about everything wound infection related, biofilms, assessment processes, planning processes, so what to do if you do get an infected wound. So it's absolutely a document you should be using if you are involved in any kind of wound care. Obviously there's a yellow document, so that again I think came out the end of last year, maybe the beginning of this year, and that's an update to a previous UMA document, and it just talks about infected wounds, what has changed from the original document. And we do know that some of our terminology has changed. We do know that some of the terminology that's now in the green one, you know, when we refer to colonisation, systemic infection, yeah, I'll put the link in, Laura, so you can directly access it. But what I do need to mention here, and Linsey, when she talks in a minute, she will very, very, far more intelligently than I am, explain around infection and non-healing. But it's really important that we touch on here, and we could talk about infection for all of the webinar and beyond. It's about that assessment. It's about that pre-planning. And clearly that image there is an incredibly unhappy erythematous looking wound. And it's about juggling those plates, isn't it? Is your wound definitely infected? If you can say your wound is definitely infected, then you treat it that way. You know, there is some mention in the document that we still haven't had any new research around actually using antimicrobials topically on non-infected wounds, but I know Linsey is going to touch on some of that with you. So it's all about making sure that you are doing that thorough assessment, you're doing that thorough risk assessment, and you're acting on what you're seeing. We know anecdotal evidence, don't we? We know what's worked on patients with certain wounds. We know by reassessing something at 2 weeks and maybe changing what we're doing, that that's having an impact. We know by having a really thorough wound cleansing and wound debridement pathway, that's having a really positive impact on wounds healing at a faster rate than what they may have been doing before. So it is really important that we do look at wound infection in a non-healing wound state. Thanks, Linsey. So what do we do? What are we going to do with this massive problem? I feel like I've come in and gone, oh God, it's doom and gloom. We've got all these wounds everywhere, and what are we doing? And I know I work clinically still, and I've been a nurse my whole entire career. I qualified when I was a little whippersnapper, and so I know what it's like out there. I know how challenging it is, and I genuinely know the pressures that you're all under. But we've got to try and make life easier for ourselves. Easier is probably not the right term, but better. So are we doing that full holistic assessment? So we're thinking about that list of all those factors that's going to make your job a little bit harder with these wounds. And are we doing that again? Are we doing that reassessment again? Are we giving strategies time to work? And then we're going, hang on a minute. We're 2 weeks in now, so our 4 week expecting this wound to have significantly improved, and it hasn't. Why? Why has it happened? Why hasn't it improved? Have we put the pathways in and the strategies? And obviously you can see there in yellow, are we using something that's an active treatment? You know, are we doing something to really help this wound to heal? Because we know our flat cap man is old, is a smoker, is really, really poorly nutritionally balanced. You know, a little bit isolated. You know, are we doing all those things that we should be doing? And actually, if we can say 100%, I have done everything for this wound and it's not improved, well then what else is there? Who are you escalating it to? Who are you linking in with? Are you speaking to your colleagues in dermatology, for example, if we're querying actually, is this it's not a leg ulcer, this could be a basal cell carcinoma. So are we actually keeping us and our patients safe so we can put our hands up and say, I have done all this assessment, bang on. I have provided this perfect optimal treatment regime that I've gone back and done a reassessment in a timely manner. And I've used really, really effective treatments for this wound, and actually there's no improvement. So always look out for those red flags or those unusual atypical presentations. Is it moving on for you, Linsey? Because it's still on the clock one. There we go.
Yeah,
Lovely.
There
So I'm going to hand over to Linsey now.
Thank you so much. That was a great introduction indeed, and highlighting what is actually the issue around non-healing wounds. So I'm here to touch on one of the treatment options that you would have for these wounds. And here at Elmesitran, we make use of honey. So why would we make use of honey in wound care? So one of the things that we know, of course, is that honey is a great antimicrobial. So if you have a sore throat or a cold, we take a spoon of honey, and we know that helps against a sore throat. But did you also know that it has a lot of pro-healing properties? And this is actually what makes honey so great for wound care. So the combination of it being an antimicrobial and it having these pro-healing properties. So I will now explain more in detail these healing properties, because I think we do know about the antimicrobial effects. So when we have our wound, we add honey on top. And what it first of all does, it exerts these antibacterial effects. So it reduces the bacterial load from the wound, which is beneficial, of course, for the wound healing. Then it also provides an antibacterial barrier, preventing pathogens from entering the wound. Besides that, it creates a moist wound environment. And it does this, I'll point it out, so by drawing water or drawing fluid from the surrounding skin. So it draws out the excessive fluid from the surrounding skin and the wound bed, preventing a wet wound and maceration. And it replenishes the lost fluid by withdrawing the fluid from the deeper tissue, from the underlying lymph tissue, and to replace the lost fluid and thereby preventing a dry wound. And we know that moist wounds heal faster than dry or wet wounds. By the same principle, it also stimulates debridement. So it will withdraw the fluid from the underlying lymphatic system. And lymph fluid contains a lot of proteases, which will help with the debridement of your necrotic tissue. Also, this constant flow from fluid will in the end also help wash the wound bed from underneath. Then it also provides nutrition to the wound. It has a lot of sugars, a lot of amino acids, a lot of nutrition within the honey itself. So this is great for our skin cells that need to proliferate and needs to build up the healthy tissue again. Besides that, it stimulates angiogenesis, or the formation of new blood vessels, and these new blood vessels will then provide the wound bed with oxygen and nutrients and growth factors from underneath the wound bed. And last, as Sharon also already indicated, in a non-healing wound, we have this massive imbalance with a lot of inflammatory factors, reactive oxygen species, and honey is has natural anti-inflammatory effects, and it also protects the wound from these reactive oxygen species via its antioxidant effects. And all of this together promotes the wound healing. So here at Elmesitran, we don't just use a honey. So you cannot just go to a supermarket and put honey on your wound, since this kind of honey still has pathogens inside, or pollutants, or heavy metals. So we use medical grade honey, which is produced and harvested according to strict criteria. So it's clean and organic, and it's gamma irradiated to get rid of any endospores or harmful microbes that are still inside of a honey. Then we also harvest from 2 different hemispheres, so the northern and southern hemisphere, in order to not be dependent on one harvest or on a season. Besides medical grade honey, our products also contain vitamins. So it contains vitamin C and E, which are great antioxidants, and they have anti-inflammatory effects. They help with collagen synthesis, so it improves the skin properties, and they have these synergistic activities with the honey against bacteria. So together they make a much stronger team. All of these alone are great against bacteria and for wound healing, but together they make a much stronger effect. Then we also supplemented our products with lanolin, PG 4000, and propylene glycol, and these are all emollients or carriers of our products. So now we'll go through our product range, and some of them are available in the UK, others unfortunately not for now. So we'll start with the Elmesitran ointment. This is an ointment with 48% honey, vitamin C and E, and essential oils. And we really indicate this one for removing the necrotic tissue and debriding the wound. Next is Elmesitran Soft. So this is a wound gel with 40% medical grade honey and the vitamin C and E. And where the ointment is to debride the wound, we would use the soft for granulation or for reepithelialization of the wound. So even though we would indicate that, or we would prefer ointment for debridement, I would also say that soft can also be easily used for debriding the wound. It's just that the ointment is a little bit better at that. Then the tulle, this is not available in the UK, but it's our non-adhering dressing, and it's coated with the Elmesitran Soft. It's used for superficial wounds up to moderate exudates and can stay up to the wound for several days. It is very conformable, so easy to use on a heel or in a cavity wound. Then, again available in the UK, is the Elmesitran Hydro, which is a hydrogel dressing with 30% medical grade honey. And This is great for superficial wounds, and it has this cooling effect. So it's also really great to use on painful wounds like a burn wound or a venous leg ulcer, for example. And I would say the best thing about this product is that it's transparent. So it has the advantage that you can observe the wound from the outside and you don't have to reopen the dressing, thereby disturbing the wound, of course. So you can leave the dressing on the wound, observing the wound from the outside without having to disturb the healing process. The Almestran border is the same as the Hydro, except for it has a adhesive border around it, and it's therefore also waterproof and showerproof. And last, this is also a hydrogel dressing, a smaller version of the border, but this is not available in the UK. And last, we have the Almestran foam, and this is a foam dressing which is impregnated with Almestran soft, and it can take up a lot of exudate. And it's also great as a protective cushioning layer, so we would also suggest to use it, for example, on pressure ulcers. And now that I went through our product range, I will go through some cases. And this is our first case from South Africa. And this was a 44-year-old female patient with diabetes. She developed this diabetic foot ulcer on her heel. And it was infected with Pseudomonas aeruginosa, which is highly resistant against antibiotics. And the lady, she already was treated for 3 months with oral antibiotics and Bactroban dressings. However, there was no improvement. So as you see the wound here at day 0, this is after 3 months of oral antibiotics and Bactroban dressings. And the patient was scheduled for an amputation at that point. And as you can imagine, for these patients, they would give anything to save their foot or their limb. So what the patient did, she went to a different wound care clinic to see if they could save her foot. And there they made use of our products, and they started using Almestran soft. And after already 3 days, they noticed that the malodor decreased, which is a great sign. And during each dressing change, there was more debridement, and more malodor was decreased, and the infection was resolved. And after 33 days, this is how the wound looked like. So we see that the necrotic tissue is removed, the wound bag looks much cleaner, the wound size has decreased, and the most important part is the foot was saved. So she did not have to go through with the amputation anymore. And this not only has great benefits for the healthcare system, so we don't need to do surgery, we don't need to do the aftercare with prosthetic limbs or with physiotherapy and the amputation wound itself, of course. But it had a massive impact on this mental health of the patient. And this was just due to using a tube of Almestran soft. Our next case is an infected heel pressure ulcer, which was in Greece. And this was a 59-year-old female patient who suffered from severe psychotic disorders, and she was institutionalized in a mental health facility. So due to her psychotic disorders, she was immobile and non-compliant. So this is why she developed these bilateral heel pressure ulcers. And these ulcers became infected. They treated her already for 1 month with povidone iodine. However, this was not successful. And they started treatment with the Almestran soft and tool instead at that point. And the important part about this case is that due to her mental health status, she did not want to have a surgical debridement of the wound. So this was stressing her out so much that the clinicians decided, okay, we're not going to do surgical debridement, we're going to just start with the soft and tool. And the amazing part here is that without surgical debridement, without stressing the patient, after 2 weeks, the wounds were fully debrided. And you can see these great results here. And this is one of the things that is great about the product or about medical grade honey in general is that it might take a little bit longer than to debride the wound, but it's much more comfortable for the patient. And then last, we have that it healed after 17 weeks. And I would like to show you a video on the Almacitran Hydro, so you can see how it looks like in the clinic. Here it's used on a leg ulcer, and you will be able to see what I was talking about, the transparency of the product. So it does need a secondary dressing to fix it, but other than that, I think it's a great product. All right. Our next case is a leg ulcer. So this was a 57-year-old female patient. She suffered from diabetes and venous insufficiency, and she simply bumped her leg into a chair. And this unfortunately led her to develop this leg ulcer. She tried to treat it at home by herself for 6 months with povidone iodine and silver dressings. However, this did not help at all. So she sought help at a wound care clinic. Here they classified the wound as a chronic diabetic venous leg ulcer, and they noticed that it showed signs of a biofilm infection. They started treating the wound with the Almacitran foam and in combination with compression therapy. And over time, they saw that the infection resolved and there was more granulation tissue and epithelialization until after 23 days, the wound fully closed up. And this was just done with 7 dressing changes of the Almacitran foam. And our last case report that I want to show is a non-infected chronic wound. So this is a chronic leg ulcer. This was in Portugal. A 91-year-old female patient living at home still. She fell and she obtained leg wounds. She obtained wounds to her legs, a medial wound and a posterior wound. And she suffered from heart and kidney failure, diabetes, and venous insufficiency. She was already treated for 3 weeks with povidone iodine, and of which 1 week combined with 1 week of oral antibiotics. And they started treatment with Almacitran ointment, tool, and soft. So what they saw over time is that the wound was debrided, the wound sizes decreased until it was fully healed in 17 days. And this is another video on showing how to use our product. So this is a combination of the Almacitran tool
we are going to
and foam.
Dressing. We have a cavity on the foot to fill it up. So this is the way we cut it, so we can maneuver it. And also have one single piece. It's much easier to extract it when we change the dressing. Okay, so we are going to do another cavity amputation. Stuff that was very, very infected, doing well with Almacitran soft and filling the cavity. So we're going to need another one for the next cavity. Actually, if we are seeing the 2 cavities are communicating, you can see coming through. So I'm not going to fill up this cavity because it's just a tiny drop of blood there. I don't want to create any trauma. I'm going to use a foam dressing. So I'll use Almacitran foam. Lovely, lovely product. Very conformable and very gentle. There you go.
Yeah, so these 2 products are unfortunately not available in the UK, but depending on where you're located, they might be available. So we'll go quickly through the other slides because I see we're running out of time. But one of the feedbacks that you might have experienced when using other honey products is that patient might complain of a pain or stingy feeling when applying the honey to the wound. And this has to do with the percentage of honey in the wound. So the higher the percentage of honey, the stronger the osmotic effects. hence the less comfortable it is for the patient. And in our products, we use a much lower percentage of honey, which is therefore also much more pleasant for the patient, and we barely get any feedback that it's uncomfortable. And if it's still uncomfortable, for example, with the ointment, you can easily switch to the soft, which is a lot more gentle. Then, compared to other products, in the top we see the ideal wound care dressing characteristics. So we want a moist wound environment to be antibacterial, should debride the wound, should be anti-inflammatory. Would also be great if it removes the malodor and stimulates tissue growth. And on the left-hand side, I put several groups of dressings. And as you can see, for example, with povidone iodine, which is commonly used, it's antibacterial and removes the malodor. However, it dries out the wound and it does not stimulate tissue growth, for example. Then with medical grade honey in general, or with almesitran, we do tick all of these boxes, and I'm happy to go later into more detail if you would like more information. But for now, we'll just close the session or the presentation. So what is almesitran good for? So we are antimicrobial. We're functional against MRSA or Pseudomonas aeruginosa. We have many case studies and also scientific studies on this, proving that we are efficient against these bacteria. It's anti-inflammatory, reduces edema. It debrides the wound from necrotic and sloughy tissue and reduces the malodor. It stimulates the wound healing in multiple ways. And it's safe and cost effective. And I would also like to add that it's quite simple to use. Overall, if you have more questions or you would like to collaborate for research or receive samples, please contact me via email on research@mesitran.com, or for more case studies and information, feel free to visit our website. Thank you.
Thank you, Linsey. I've popped in the chat box the links to the 2 documents that I mentioned about wound infection. Definitely download those and use them, because they are so helpful in clinical practice, especially if you're wanting to put together your own pathways, strategies around managing non-healing wounds. They are really, really helpful at guiding that. I know in Manchester, my colleague has put together a really effective pathway looking at wounds. So we're looking at that 2-week point, that midpoint between your 2 and your 4, where you'd expect to see a change, and they've put some really, really good strategies in. So definitely use those. I will also pop in the chat box the marketing website. I think you may already have it when you signed up, the marketing email. If anybody would like any more information here in the UK from any of the sales team or from myself from a clinical point of view, then please do get in touch with us as well. I'm not sure if anyone's got any questions. If you have, while I'm typing this, I'm giving you the opportunity. We're a quiet group.
Yeah, Sharon, I don't think we've had any questions, so they just must be blown away with the information.
Blown away. They knew it all already anyway. Yeah, you've got Linsey's email, so that's Linsey's email, research@mesitran.com, and you've got the marketing email, so marketing@hrhealthcare.co.uk. As I say, sorry, I have to sign out now. No worries. Thank you, Maria. Claire, oh hi Claire, meant for packing. So unfortunately that video, we don't have it here. We literally only have the ointment in the UK, the ointment, the soft, and the hydrogel version. So we don't have anything that you would use for packing in the almesitran range. Hope that answers your question. I think that's what you're asking me. Obviously that was the tulle, was it, in the video, Linsey? Is it the tulle dressing? Yeah. But if you do have any other questions after the session, I know loads of you've got to go.